All right, let's dive into a complication that I'm sure every surgeon really dreads, the high output stoma. This is a serious, potentially life-threatening issue, and it demands a really fast, systematic approach. So today, we're going to break down exactly how to manage it. Just before we jump in, a quick but important note. This content is brought to you by the Surgical Edge podcast, and it's for educational reference only. Please always follow your local clinical guidelines when you're managing patients. So here's how we're going to tackle this. We're going to follow the whole patient journey right from the start. We'll define the problem, figure out how to diagnose it, lay out a clear step-by-step management plan, and then talk about what to do when that plan isn't quite enough. And we'll finish up by looking at how to set up that all-important long-term care. Okay, so first things first, what exactly is a high-output stoma? And more importantly, why do we need to treat this as a true clinical emergency? It really all comes down to one thing: volume. The output is just so high that the body simply can't keep up. And this isn't some minor inconvenience. It's a full-blown physiological crisis that can quickly spiral into severe dehydration, massive electrolyte losses, and, you guessed it, acute kidney injury. So what's the magic number we're looking for? Well, you'll often see 2,000 milliliters quoted in textbooks, but honestly, your clinical alarm bells should be ringing much earlier. Any stoma that's persistently putting out over 1,500 milliliters a day, well, that's your signal to intervene, and you need to do it fast. Okay, so what are you actually going to see at the bedside? Let's build the diagnostic picture, looking at both the clinical signs and what the lab work is going to tell you. You're going to see the classic signs of dehydration, no real surprise there. But the one I really want you to focus on is the urine output. If that drops below 0.5 ml per kilo per hour, that is a massive red flag. It's telling you your patient is significantly volume depleted and their kidneys are in trouble. And the bloods, well, they just confirm what you're already suspecting. You'll see this predictable pattern of loss: low sodium, low potassium, but you have to pay special attention to the magnesium. Small bowel fluid is incredibly rich in magnesium, so these huge volume losses can cause a really profound and rapid drop. And of course, that rising urea and creatinine confirms that the acute kidney injury is well and truly underway. So here's the crucial part. We don't just throw the kitchen sink at the patient all at once. The management is systematic. Think of it like a pyramid. We build up our interventions, starting with the most foundational therapies first and escalating from there. And it really breaks down into 3 clear steps. Step 1, we hit them hard and fast with resuscitation and medication to get things under control. Step 2, we modify their diet and fluid intake. And only if those first 2 steps fail do we move to step 3 and get the specialist intestinal failure team involved. These are our pharmacological workhorses. Now, notice that loperamide dose. It's way higher than you'd use for standard diarrhea. And here's the key. You have to give it 30 to 60 minutes before meals to really maximize its effect. We add codeine for a synergistic effect, and a high-dose PPI like omeprazole to help cut down on the volume of gastric secretions feeding into the problem. Now, this next point is absolutely vital, and it's something that gets misunderstood all the time. You have to teach your patients to strictly limit hypotonic fluids. That means things like water, tea, and coffee. It feels completely counterintuitive, right? But drinking these fluids can actually make the sodium loss worse. Instead, they need to be sipping on specifically formulated glucose electrolyte solutions, like St. Mark's solution, which are designed to optimize fluid and sodium absorption. So that brings us to the big question. You've optimized all the meds, you've given the strict fluid and dietary advice, but the stoma output is just stubbornly high. What's your next move? This is the point where we have to pivot. We have to stop just managing the symptoms and start investigating the root cause. Because, let's be honest, you're never going to get effective long-term control if you don't understand what's driving the high output in the first place. Your go-to first-line investigation is going to be a CT scan of the abdomen and pelvis with oral contrast. It's simply the best tool we have to look for a correctable anatomical problem. Things like a partial obstruction from adhesions, maybe recurrent disease, or even a stricture right at the stoma itself. And I really want to be crystal clear on this point. Surgery is not the first answer here. It is absolutely a last resort, reserved only for those patients who have failed maximal medical therapy and, this is the crucial bit, have an identified correctable problem that we can see on imaging. Finally, let's talk about the long game, because getting a patient stable in the hospital is really only half the battle.
Achieving long-term control and, just as importantly, preventing readmission, that's not a solo effort. It absolutely depends on a well-coordinated, multidisciplinary team. I want you to think of the care team like a circle. You've got the surgeon, the dietitian, the GP, but who is at the absolute center of that circle? It's the patient. An educated, empowered patient is, without a doubt, the single most important member of this team. And everyone on that team has a vital role to play. The GP is managing the prescriptions and keeping an eye on the bloods. The stomach care nurse is that crucial link in the community, constantly reinforcing education. The dietitian is tailoring the diet, and the surgical team is overseeing the whole strategy. Together, they create this incredible safety net for the patient.
And really, if you take one thing away from this today, let it be this. Success isn't just about prescribing the right drugs in the hospital. It is built on a foundation of seamless, collaborative, long-term care that bridges that gap between the hospital and the community. So, I'll leave you with this final thought to chew on. Beyond all our clinical interventions and our fantastic multidisciplinary teams, how can we do a better job of truly empowering our patients? How do we help them become the primary expert in their own condition, giving them the tools and confidence to self-manage and, crucially, to recognize those early warning signs before it becomes a crisis again?